I'm Vera Rose. I'm the SHOT incident specialist. Unfortunately, Laura won't be able to attend today, so I'm going to thank Julie Jackson to help me presenting today. Julie Jackson is a transfusion practitioner at the James Paget University Hospital, and she's going to be giving her personal experience or professional experiences in the case studies. Just to say, the case studies that you are going to look in here, we just collect information. SHOT just collects information. We don't change any information. So all of the information that I'm giving, it's just anonymized information from the reporters. So next slide, please. So just some learning points. So we are going to look at the SHOT data related at anti-IgG errors, especially for 2023. Then we're going to look at some SHOT cases related to NTD and what it was the investigation and the actions that were implemented by the hospitals or by the healthcare organizations that reported to us. And Julie is going to share some alternative actions. Next slide, please. So we are going to talk about SHOT. So we are going to focus on errors, what went wrong. But I wanted to take some seconds to first recognize that usually things go right. Usually every day, we should learn from everyday events, because when we are doing the best, and usually the best that we are doing, it is correct. So we need to recognize that. And we also need to recognize when an incident happens that has an impact on the person. Usually, like, the human brain is always attached to the negative things that go wrong. So we need to be kind when you're doing an incident investigation. You don't should look at who did it, but actually why the incident happened, what on the system allow the error to happen, not have get away from a blame culture, because that has an impact on the healthcare professional involved in the incident. So next slide, please. So we are looking at the data from 2023. So apart from the near misses, so the near misses is where the error was identified before administration of NTD or before the transfusion of a blood component. So when we are not looking to that, NTD immunoglobulin errors has been the highest category that has been reported to us. And it is the category where all of the errors were completely prevented. And this was not just in 2023. Since 2021, the anti-IgG errors represents almost 25% of the total errors that are analyzed by SHOT. Next slide, please. So we are going to look at the errors that it was submitted to SHOT. So the majority of them, it is omission or late administration. As you can see on the blue, it was 284 reports that we have received in 2023. And mainly it is the charge before administration. It can be at post delivery, or it can be after a potential sensitizing event. Usually it is communication failure. It is no handover in the department or between different departments, or, for example, following the wrong process. For example, the clinical area is waiting for a CLI-HAWA result before administration, or the potential sensitizing event. Sometimes the lack of knowledge if the case is actually a potential sensitizing event or not. We have also cases where there's a failure to order, and that includes cases where the RDP, the routine antenatal prophylaxis appointment, was not booked, or the patient didn't come, but he was not chased up, the patient, to come and receive the dose, or even when the patient is a complex and is being looked at by different teams, and there's an assumption that the other team is the one responsible to give NTD. Or also it can include failure to check results. It can be the status of the mother or the status of the fetus are not looked at. And we had 36 cases where there was an incorrect decision to omit the NTD. They make a decision that the patient did not need NTD. And from those 36 that we have received, 30 it was where patients have been seen outside the maternity or gynecology wards. Next slide, please. The second most common error that we've seen, it was the anti-D-IgG given to mother of a D negative infant, and on the clinical areas is mainly on the cell-free fetal DNA that has been actually talked about in the previous presentation. The results are not checked, and the patient receives the anti-D when it's not needed because it was predicted as D negative. On the laboratory side, the errors, we received 44. 26 of those cases of the 26 out of the 44, it was because it was the predicted D status was wrong. So it was predicted as D positive, but then when the baby born, it was actually D negative. And even though there's no error in the hospital, but we received those cases. Also, there was other errors, for example, results not checked. For example, the Klahawa is sent to BMS, does the testing, he sends the and then he issues the NTD without checking the results, or the NTD is just requested and is not even looked at the cell-free DNA of the cord results if they are available. There was also 2 cases. One, there was a transcription error of the D status, and there was another case of the misinterpretation of the results from the analyzer, and it was given when the patient didn't need it. Next slide, please. But as you can see, there's a lot of reasons why we receive reports related to NTD. It can be the NTD IgG is given to a woman with immune NTD, even when there's flags on the limbs or on the clinical area IT system, maternity IT system, there's flags, but it is completely ignored. So the patient receives NTD when they shouldn't. NTD handling and storage errors, it is those cases where usually the laboratory has issued the NTD, it is collected and it puts on the drug fridge. And there was a case that the NTD was only found out 3 months after that he was still sitting in there in the fridge, and the fridge is not temperature monitoring, is not monitor the temperature, so it shouldn't be used. We also have NTD IgG given to a D positive woman or NTD IgG given to the wrong woman. In these cases is where the positive patient identification is not carried out at the administration. The right product, right patient, it is when the patient needs the NTD, the dose is correct, that is the dose that the patient required, but the label attached, it could be the date of birth is wrong, or there's a misspelling of the surname. So this is where it fits in this category. Next slide, please. So why we are looking at the NTD IgG errors? So we have another category, SHOT has another category that is called NTD immunization. This is the cases where the pregnant patient has been immunized during pregnancy, or when NTD was firstly identified during pregnancy. This category is not for NTD IgG errors. That is a different category. Sometimes it is the patient received the NTD correctly, everything was done correctly, but the patient produced immunity. We receive these cases to understand what is the contributory factors for desensitization that is not due to errors. So we separate on cases where the patient had been previously pregnant or not. So in this case, in 2023, we have 7 cases where the patient had not been previously pregnant. All were resulting in live births. But as you can see, more than 50% required some kind of treatment for HDFN. And this shows, if you can move on, we had 35 cases where the patient had a previous pregnancy, and 32 resulting in live births. But as you can see, 15, that is almost 50%, required some time of treatment. It can be phototherapy, it can be transfusion, it can be any being range. So as you can see, it is important. That's why we look into them. Even though, as I said in the beginning, we usually do the right things. When you compare how many cases, how many patients receive NTD, we usually do the right thing. But when things go wrong, we need to look into them so we can make it better, because there's actually an impact from the patients not receiving the NTD, either the wrong dose or after the correct time frame. So next slide, please. So we are going to look at the case studies. So the first case we have, the case studies they represent the most common cases that we receive. So this patient, it was discharged before administration. So there was a D negative patient, he delivered a D positive baby. A Kleihauer sample was sent, it was tested by the lab, and NTD was issued. 2 days later, the patient attended for NIP, but the requirement for NTD-IgG was not noted until the patient had left the ward. So then when they realized the error, they called the patient back, but the patient could only attend after the 72 hours post-delivery. Communication issues between the staff on delivery suite and postnatal ward was identified as one of the reasons why the NTD was not given before the patient was discharged. So on the next slide, please. So the actions that were implemented in the healthcare organization that reported was, it was to have an NTD log in the maternity fridge to track NTD received from the laboratory. That also included out of hours. The laboratory introduced a fail-safe to check maternity fridge and contact ward if NTD had not been collected. The communication was sent out to all staff as a reminder to review the patient's status when attending. It was highlighted when booking for NIP, NTD might be required, as well as the Kleihauer results. And the last one, it was the board to record the patients that required the Kleihauer results were required to be chased. So, Julie, now, please.
Good morning, everyone. Just to say on Laura's behalf, Laura is a TP midwife in the Northeast, and we'd asked her to come and talk to us because she has a foot in both camps, so to speak. But sadly, due to personal reasons, she's not able to attend. So I'm going to do my best. So the first thing we're going to look at is active action effectiveness. So I'm sure you may or may not have seen this. It was first produced by SHOT in 2022, and it's looking at what actions are the most effective. So let's have a look at the actions that were put in for this. So all these actions are down here in this purple. They're changes to rules and policies, they're reminders, and their education and training. So what we want you to think about is, okay, that's all good, but the problem we all know with checklists is, well, they're human failure because we don't fill them in. So think about how we can move something up into the green. So some suggestions. The majority of your ladies do not need extra anti-D. So a Kleihauer test is a really tedious test. It is time consuming, and if your BMS is on call, the only person on call, any interruption, any distraction may result in the result not being accurate or not being done. So if the majority don't need extra anti-D, why are we putting the majority at risk because of the very small minority that might? So certainly my trust and quite a few others have taken the decision that as soon as we know the baby group, we issue the routine dose of anti-D. Kleihauer gets done when there's a lot of people around, so it's more accurate and there's more effectiveness. And we then have a very, very small minority that we need to chase up to make sure that everything gets done. This is here, it's low on the green, but it's about simplification, simplifying things. It's standardizing and simplifying. If you've got an electronic system, consider having an alert to the lab if the injection's not collected. So again, you've got some automation and computerization thrown in, that instead of somebody having to check everything, you've got an alert that comes up when it's done. What I would like to ask, if anybody has any other alternatives or for preference, a forcing function. Forcing functions make you take the action. They're few and far between, unfortunately. But if any of you've got them, please put them in the chat for shared learning, because that's how we, like Vera said, 99% of the time, I think we are safe. We do everything right. So we need to learn from each other. So we may not have had this error, but we can learn from you having the error, and we can learn from what you did for the error. So please do give us some shared learning. So the next case study is about a knowledge gap relating to anti-D requirement when cell salvage is used. Wonderful talk by Tamsin earlier about using cell salvage in major hemorrhage and the potential risks of amniotic fluid and fetal cells being put back into mum's circulation. Well, this is about that. So this is a DNEG patient, received cell salvage. It was documented in theatre, but nobody recognised the need for a higher anti-D Ig dose. So they had the 500 IU that is recommended as the minimum dose given after birth, and that's all they requested. And they sent the samples to the lab, but they didn't say that it was a cell salvage. So CLIA result was less than 2, and the baby's group was D positive. So that first initial dose was given. It was then recognised that actually, because she'd had cell salvage and because of the risk of, even though the CLIA result said less than 2, there is a higher risk because you're transfusing fetal cells back in the maternal blood you transfuse back. And it was recognised that she needed more, and the further 1000 IU was given, but that was outside of the 72 hours. So what accidents did they take? They sent out a communication. So they did a little bit of education to consultants, junior grades, to share and to remind the requirement for larger anti-D. They have a blood conservation coordinator, shared the incident with the theatre team. So again, a little bit of education there. Practice development midwife, education. Requests for reviewing the the transfusion request form. So this is about putting on the request form for the anti-D that cell salvage had been given. Mandatory study day, again, education, and looking at the potential when a new electronic patient record system goes live, that they would be able to put in a forced alert. So the alert says, prompting the midwife to do cell salvage. So again, we're going to look at those actions in line with the effectiveness grid. So the majority of the actions were actually down here. They were about putting in checklists, education and training, changing rules and policies. We have one up here, which is a new electronic patient record system in maternity, but this is a future one. And the infected blood inquiry released last year highlighted that we shouldn't rely on what might happen. So we shouldn't go, well, we're not going to do anything now because in X amount of time, this is going to happen. Unless that X amount of time is finite and you've got an introduction date, don't use that. But it's good to put it on the line that this is something that's going to happen. And again, this is higher up the green box. Think about simplifying and standardizing. So, okay, the guidelines say a minimum of 500 IU, but a max 1,500 IU is absolutely fine to give. So I know that our trust and quite a few other trusts have changed their SOP. So they give 1,500 from a set point in the pregnancy. We use 20 weeks because then we know 20 weeks, CLI hour, 1,500 IU. So therefore, 1,500 would be your standard dose. So there is no issues with the fact you only gave 500. So there are things to consider. Again, if you've got any alternatives or a forced function, which would be wonderful, that would be really good. And just to say as well, to remember that if your cell salvage is used as part of your delivery, that's your delivery anti-D. No extra is required. So that would be your delivery anti-D. If it's used during the pregnancy, but not part of delivery, then you've also got to think PSE. So you've got to be thinking about PSE, but the lab will advise you. Again, communication, talk to the guys in the lab, they will give you advice. Our third case study is about incorrect manual input on maternity IT systems. Hopefully, those of you who use BadgerNet will have been made aware of this. BadgerNet does not have a automatic link to the lab information management system. So the patient blood group is put on manually, and there was an error. The patient blood group was put on as D positive. But when they attended a routine appointment at 35 weeks, she mentioned, oh, I'm actually D negative. So the system was then checked, and basically they discovered that there was this transcript error. again, main contributory factor, lack of interoperability between the records. So what did they do? They shared the event, so learning. Patient group to be checked on the main electronic patient record, not the maternity IT system. Liaise with maternity records software team, IT solution. And just for support, SHOT have released this script, which is about all the IT issues, getting the interface between the lab system and the patient record system. It's a really good tool to use if you're trying to justify extra equipment as well. So again, let's look at the action effectiveness. So we had education and checklists again. So yeah, they are good to put in. Again, the only issue that we have is that the more layers you add in at this level, the more likely you are to have an error, believe it or not. The patient blood group to be checked on the main electronic patient record. I've put that down here, but for one reason only. I didn't know if that had been, oops, I've got them in the wrong order, if basically they'd taken away the need or taken away the field for putting in the group manually. So you could change that into a simplification standardization by changing that. So if you know that you haven't got a LIMS system, so that group isn't going to go across automatically, then you don't use it. You take away that facility, and instead you would put a link to the lab information result system, be that ICE, be that whatever, so that every time you are going back to the source, you're going back to the reality. And obviously with this one, they had the liaise with maternity records software team. This is always something to think about if you're scoping new software. Always look at things like this about getting the interface with all the other systems and just double checking things. And the only other suggestion I would make is if you do have to have manual input of results, then it is a check to throw in, but have two people. So it's never just one person who is putting that result in. It has to be checked by a second person to show that actually the mistake wasn't made by the first person. Not ideal, but if you have to have manual, then you can put that safeguard in place. Okay. So Vera, back to you.
Thank you, Julie. Just to say, so the script, it was issued a problem statement and impact, as Julie has shown, when we knew the maternity IT system. If you have any IT system that you can see that it causes a transfusion safety problem, just let us know. This is how the problem with the maternity IT system was made aware to us. It was a reporter that had the problem, and then after understanding the problem, that's why it was issued the problem statement and impact. So just let us know. So because the NTD, as I mentioned, it has been the highest reporting category. So we have created a lot of resources to help the healthcare professionals. So we have done the short bites, that is like a two size document with focus in different areas. We also have created some short videos. We have also what is called the signatures, where you can use them on your email, and it's just those signatures is to come across or to increase awareness of a certain message, safety message. And also the latest document that we have issued, it is the short safety notice for NTD that it has been created also a gap analysis tool. The gap analysis is just for you to look at your practices and check against guidelines. When we're doing this document, obviously we know there's different practices in different healthcare organizations, but it is just for you to assess your practice. So this is all available. This is all available on the SHOT website. There's a new SHOT website, so please go there and check all the resources that are completely available and free of access to everyone. And if you find anything, any resource that is not there and you think it will be useful, just let us know and we'll look into that. And thank you for listening to us. And if you have any questions, we are happy to take them. Thank you.